So it is my great pleasure to introduce our speaker today, Dr. Susan Liebman. Dr. Liebman was one of the first female undergrads at MIT, and she received her master's in biophysics from Harvard and a PhD in radiation biology and biophysics from the University of Rochester. Then as a professor at University of Illinois at Chicago, she led a very well-funded research group in molecular genetics and was the PhD mentor of my good friend, Professor Pinzo, in the stem cell program at UC Davis. So that's how we got connected. In the last decade, Dr. Liebman is also a research professor in pharmacology at the University of Nevada, Reno. She took on the role of a medical detective, which her niece unexpectedly passed away at the age of 36 as a result of her findings. She became a strong advocate for genetic testing and is the author of an upcoming book titled The Dressmaker's Mirror, Sudden Death, Genetics, and a Jewish Family's Secret. Her book weaves stories of the sorrow of a mutation caused the Liebmans for generations with information about the crucial role of genetic testing in safeguarding personal health and patient care. So this is also a topic of Dr. Liebman's talk today. So without further ado, here's Dr. Liebman.
Thank you so much for the kind introduction. Please interrupt if you can't see or hear or something goes wrong technically, let me know. And I guess you've seen this introductory slide before about being muted and questions at the end. So what we're going to be talking about today is how to improve your patient outcome with genetic testing. And as you know, no healthy people think that they're going to suddenly die, and neither do their healthcare providers. That's something that happens to somebody else, doesn't happen to us. We don't worry about it. But I have been struck by the fact that sudden death was hovering over the 1996 Princeton graduation. I was there, younger, with my son when he graduated that day, and my sister and niece. Karen had traveled, was 23, and she had graduated from college a few years ago. She was active, traveled the world, became fluent in French. She was involved in community theater, and she had become a third-grade teacher, was adored by her students. That same day, Grant Wald was in Michael's class, and here he is at the prom with his to-be bride, Celine Gounder. Celine became a physician and a medical journalist. Grant became a well-known sports writer. So let's fast forward. This is 13 years later. In the intervening time, Karen had attempted to actually become an actress, went out to LA for a short stint and had a short, unsuccessful marriage to another aspiring actor. And then she, years later, reconnected with a high school friend, and they had a whirlwind romance, and within a short time, they were married. They were thrilled that despite her age, 36, Karen got pregnant, and here they are celebrating Andrew's 37th birthday with Karen showing off her baby, her belly. And she had complained about getting out of breath when climbing stairs. And her doctor said, oh, you're 6 months pregnant. Every woman who's 6 months pregnant gets out of breath. And you have a cough, yeah, well, you're surrounded by third graders and all their germs, nothing to worry about. So the day after this picture was taken, they went out to a restaurant, and just as they were about to leave, they just had a snack there. Karen slumped down in her chair with her eyes wide open, and she was unresponsive. An ambulance arrived within minutes. This was in Brooklyn Heights, so they were very close to hospital. And they were unable to restart her heart. And she was pronounced dead a few minutes later in the hospital, along with her dead baby. The autopsy report at first showed nothing, but they sent her heart away for further testing. And we were astounded when they came back with the report that she had dilated cardiomyopathy. And this shocked the family because my sister had some years earlier in her 50s been diagnosed with dilated cardiomyopathy. But her doctors, since there was no family history, since she didn't have diabetes or something that could have caused it, she wasn't on cancer drugs or any other kind of drugs that could have caused it, they said this was caused by a virus, that a virus can have this side effect, and that's what we believed. But of course, after my niece got the report that she had had dilated cardiomyopathy, I'm a geneticist, I figured this out, this was genetic. And that began our search for the lethal mutation that caused this. But that's a story for another day. So we'll go on to what happened to Grant Wald. This is 26 years after his Princeton graduation, where he, again, this is a day or two before he died while covering the World Cup at Qatar. I actually met Celine on a occasion when we were both representing families at the New York City coroner's office is trying to get coroners to medical examiners to save remains so that they can do genetic tests on people who die suddenly. Neither Grant nor my niece Karen had any idea that they were sick, had any idea that there was family history. It was a total shock to both. Okay, so now that I hope I've captured your attention and I've captured your heart, let's look at the problem that I'm here to discuss today. A recent Becker's Hospital Review asks this question. Cardiogenomic testing is a must for certain patients. So why is its adoption by cardiologists so low? So this is like a pre-test. I'm gonna ask you a question and you can put in chat yes or no, and Jenny will tell me how we're doing. Should you test your patient, genetic test your patient, if you already have a diagnosis? So Jenny, do we have any responses?
Yeah, I have 2 yes, or 3 now, so.
3 yeses, okay. So that's very good. The answer is yes. And why should you already test if you have a diagnosis? If we weren't so limited, I'd ask you, but here I'm going to answer for you. There's 2 reasons. One is that knowing the gene can affect how you actually treat your patient. So Dr. Michael Ackerman of the Mayo Clinic points out that patients with mutations that have long QT type 1 are treated differently than patients with long QT syndrome type 3. Knowing the gene can tell you which type of long QT syndrome your patient has. Treatment for sarcomeric hypertrophic cardiomyopathy is different from treatment for a mimic disease, Fabry disease. And the other reason is to help save the family. So cascade testing finds additional at-risk family members in over 40% of those tested. So what should we actually be, genetic, so what does genetic testing help with? It helps with the 3 pillars of medical practice: diagnosis, prognosis, and therapy. And in this slide, the different types of cardiac diseases are rated for how much genetic testing helps in these 3 pillars. So it's very helpful in arrhythmia syndromes, in cardiomyopathies, and in congenital heart disease. You can see lots of pluses here showing that it's quite useful. Okay, so when is genetic testing recommended? Any patient that has cardiomyopathy, dilated cardiomyopathy, hypertrophic cardiomyopathy, or arrhythmogenic cardiomyopathy should be tested even without a family history, just the fact that you have a patient that has this disease, because 50% of them are caused by a genetic mutation. The only time you might decline genetic testing is if you know that the cause is due to a heart attack or coronary artery disease. Patients with channelopathies, likewise, should always be tested, even without a family history. Aortopathies, such as Marfan syndrome, high-cause genetic and family lipidemias should be tested all the time without family history. So given those recommendations, this is very recent from Becker's review, how are we doing? How often? Think about it. What do you think? Can't ask you that because we're not connected, but what percent of the time do you think people with dilated cardiomyopathy are actually being sent for genetic testing? And here's the dismal response. For dilated cardiomyopathy, instead of 100%, we have 0.8% of patients being sent for genetic testing. Long QT, 1.2%. Hypertrophic cardiomyopathy, 1.6%. I mean, this is a little better. Hereditary amyloidosis, 6%. But it's painfully low. Why is this? What's the problem? What's going on? And how can we fix it? Hopefully, the young doctors will spread the word as they go into practice. So I think the problem is various myths. There's the myth that genetic testing costs thousands of dollars. But in truth, most patients pay less than $100. Often the out-of-pocket maximum for the patient is $250 or less. This is because of the tremendous increase in technology in DNA sequencing. You know, a decade ago, it did cost thousands of dollars. Actually, maybe 15 years ago, it might have been $50,000. But that's not true anymore. There's a myth that ordering and interpreting a genetic test is very complicated. You have to be a geneticist. You know, regular cardiologists can't do this, or a GP. It would be too hard. But in truth, you can order the test and have it interpreted very easily by genetic companies, and they'll provide genetic counselors to talk to you and to talk to the patient. You don't have to know it all or any of it. They'll tell you, but we're going to teach you a little of it. There's a myth that sudden cardiac arrest only occurs to those with a known heart issue. But in fact, sudden cardiac arrest is often the first symptom, or can be the first symptom of a heart problem. Myth, sudden cardiac arrest only happens to old people. Unfortunately, genetic heart conditions can affect people of all ages. Well, of course, we know that bad genes aren't the only cause of heart disease. It often results from environmental factors. Alcohol, drugs, diabetes, smoking, obesity, pregnancy, virus do all cause a heart disease. But we also know that now there are over 100 genes that can cause heart disease. And if you add environmental effects to someone who has a gene that causes heart disease, the effect is multiplied. So there's evidence that the environmental factor is often a second hit in addition to having the gene. And this can explain why one family member with the same mutation gets heart disease while another family member does not, because one had an environmental factor that added to the genetic predisposition. But it's also very important to realize that just because you know of an environmental factor, someone has diabetes, don't forget don't decide that's the only reason and we shouldn't test them for a genetic cause, because 1 in 5 people with an environmental cause of heart disease also has a genetic mutation that caused the heart disease. Mutations enhance cardiomyopathy in pericardium. They enhance cardiomyopathy in alcohol-induced cardiomyopathy, and they enhance cardiomyopathy in cancer therapy-induced cardiomyopathy. Again, the important thing is, if you have a patient that you think you can explain the cardiomyopathy by one of these environmental factors, still do a genetic test. You could save family members. Okay, so what is the genetic basis for heart disease? It can be caused by a number of things. First is a mutation in a single gene. And those are what we're going to mostly be talking about today. So I'll circle that. And these mutations can have a big effect. It can also be caused by mutations in several genes, and these are oligogenetic cause. And a mutation in one gene, in this case, will have much less of an effect. You need all of the mutations to have a big effect. And then polygenic cause can have just a little effect if you have a mutation in one of the genes, but if you have many of these mutations, then the effect can go up. Mutational cause is not rare. I guess it depends on what you consider rare, but 1 in 500 people in the United States have hypertrophic cardiomyopathy, and 1 in about 250 have dilated cardiomyopathy. And about half of these people, it is caused by a monogenic mutation. So let's do a quick review on how monogenic mutations cause disease. We each have 2 copies of every gene, one from our father, one from our mother, and they're not always exactly identical. There may be variations, but they don't cause any problems. So there's lots of good copies. They're all good copies, but they're slightly different flavors. And each of these genes are transcribed and translated to make a bunch of protein that you need. And in this case, you need for good heart function. If, however, one of the copies is really got a bad mutation so that you don't make any of that good protein, then if you only have half the amount of protein, and that can cause disease. In that case, the mutation is said to be dominant. Most of the mutations that cause heart disease are dominant, and most of them are in autosomal chromosomes. That is, they're not in the X or Y sex chromosomes. So what result are you going to get if you send your patient for genetic testing? The genetic report is going to tell you that they sequence the genes that could have caused the heart disease, and all of the genes your patient has are benign, no problem. Or they might find one that's likely benign. They may find some that are uncertain. These are called variants of uncertain significance, likely pathogenic or pathogenic. So what kinds of mutations this is more than you need to know, but I'm going to just review it quickly. I know you've all studied this in the past. What kinds of mutations could you expect to be classified as benign or pathogenic or something in between? If you have a mutation that doesn't change the protein sequence, just changes the redundant codes in the codons, then it's likely to have no effect at all. If you have a mutation that changes a single amino acid called a missense mutation, so instead of glycine inserted at this position in the protein, you have an arginine, that may or may not cause a problem. Often a change in a single amino acid, unless it's in an important part of the protein, isn't a big problem. On the other hand, if you have a base pair change that creates a nonsense codon, a stop codon that says stop making the protein here, unless that occurs toward the end of the protein, it's likely to cause loss of function. If you lose half the protein, that's probably not very good. Likewise, if you have an addition or a deletion of a base pair that causes a frame shift so that the reading of all the codons is now messed up and the rest of the protein is gobbledygook relative to what it's supposed to be, again, unless that occurs at the end of the protein, that's likely to be a loss of function mutation. There's another kind of mutation that I want to talk about, but before I can tell you that, I have to remind you about exons and introns. In humans, almost all of the proteins are interrupted, genes are interrupted with introns. So the exon portion of the DNA for the gene codes for the protein, and it's spliced together to make a messenger RNA that is then translated into protein, and the introns are thrown away. Actually, the introns are much, much larger than are shown in this cartoon. And in addition to introns, we have a lot of DNA between genes that's not shown here. So 99% of the genome is introns and stuff in between genes. So another common type of mutation is a splicing mutation. You're supposed to put these 3 exons, and often there's many more such exons, and again, the introns are much bigger, together in the messenger RNA, spliced together like this properly. But sometimes they're, because of a mutation at the edge of the intron, either right at the edge of the intron or the edge of the exon, they're spliced incorrectly. And then you might skip an exon, or you might skip a splicing, and that can cause a loss of function mutation. That's another kind of common mutation. So back to the findings that you're going to be told when you get your report from the genetic testing company. Keep in mind that different companies may score the same mutation differently. They're looking at slightly different data. Also keep in mind that the answer you get is a snapshot in time, because as more data comes out, we get more of an information. So they're deciding this on the basis of something's going to be called benign if lots and lots of healthy people have that change. It's just a different flavor of the gene. Likely benign, it's not quite as many other people, but a lot of other people have. Uncertain, they don't have enough information. Not very many people have that change, and so they really don't know what it causes. Likely or pathogenic it's a kind of mutation that clearly causes loss. It's a stop codon in the beginning of the gene or a frame shift in the beginning of the gene, and they know that loss of function in that gene causes pathology. Or they actually have that very specific mutation in a lot of people who have the disease. So over time, I think this will change as more data comes in. That's why it's useful if you don't have, especially if you don't have an answer, if it's uncertain, to have repeated testing. And the other thing I want to point out is that even if you get a clearly pathogenic mutation, they tell you your patient has this mutation, it causes disease in lots of people. In your patient, it may never cause disease. So what you have to do is follow up clinical testing to find out. More frequent follow-up clinical testing than you would do for someone who doesn't have the mutation. But there's no point treating them if they don't have disease, and they may never get disease. Okay. So what to do with the variant of unknown significance? This is a big problem in genetics right now, and I'll just tell you my thought and recommendation. If you've done the genetic sequencing on a patient just for interest, to find out the screening, which I do recommend, but is not yet recommended by the agencies, and I'll explain why. But you're allowed to. If you do just genetic screening testing and there was no disease in the patient, no disease in the family, I would ignore a variant of unknown significance. You're going to get too many of them to worry about. If you're doing the testing on someone who has, for example, cardiomyopathy, and you find a clearly pathogenic mutation in one of the genes that causes dilated cardiomyopathy, but you also find a variant of unknown significance, I would focus on the pathogenic gene and let the variant of unknown significance go. However, if there's pathology and no other genetic explanation, none of the genes that we know can cause this disease have a pathogenic mutation, then you need to focus on this variant of unknown significance and re-examine it in a few years. They might know by then. Another thing you could do is test 2 other relatives of your patient, parents if they're both alive, or cousins on different sides of the family, and see if people in the family who have disease have this variant of unknown significance or not. And that can help you decide if it's relevant. If the people who have disease don't have this variant of unknown significance, it's probably not the cause. And vice versa, if people who have the variant of unknown significance don't have the disease, although it might not show yet, it's less likely to be the cause. The other thing you can do is, if you're very conscientious, is look up the variant in one of the websites, ClinVar, that can give you more information. But this is above and beyond. What you really want to do is send the patient back in a year or 2. Keep retesting and let the genetic company figure this out. And they may recommend trios. Okay, so let's summarize so far what we've talked about. Genetic testing can help your patients because they can detect disease early if you do screening, but it doesn't help unless you do a genetic follow-up, a clinical follow-up. We talked about the fact that knowing the mutation can tell you what kind of therapy to use, and that knowing the mutation can help you protect the family members. Those that carry the mutation can go for early treatment and clinical examination to see if they have disease that can be treated early, and others in the family can be reassured that they're not going to have that problem from this mutation. So knowledge is power. So I did want to talk about the fact that we have about 25,000 genes in the human genome, and about 7,000 of them are believed to be able to cause disease if mutated. And we know what some of these are, not all of them. But among this list, I want to draw attention to what we call actionable genes. And there are currently different organizations list different numbers of actionable genes, but the American College of Medical Genetics and Genomics, ACMG, lists 81 genes among their actionable genes panel. And ClinGen lists 140 genes, but still it's not 7,000. Actionable means that you can intervene to make a difference in life expectancy and quality of life. 1 in 50 adults has a mutation in one of these 81 genes. So what they tell you, what ClinGen and American College of Medical Genetics and Genomics tells you is, if you are sequencing a patient's genomes for some reason, suppose they have cancer and you're trying to figure out if they have BRCA, and you sequence a bunch of genes, and by accident you sequence something that shows a mutation in one of these 81 genes that's not related to cancer. It's a heart disease gene. You're supposed to tell them. So secondary finding, if you have it, you tell them. But they still don't recommend that you do general screening, largely because they don't think there's enough genetic counselors out there to handle it. By the way, if you come across a new gene that you would like them to include in their panel of actionable genes that's not on the list that you think should be, let them know. They will have their team consider it and add the gene. And indeed, the gene that was found in my family has been added to this list by asking them. So among this list of currently 81 actionable genes, 38 of them are cause cardiovascular disease. So you'll recognize these diseases. 38 genes, single genes, can cause these diseases that you can treat. So we focus on actionable genes to avoid having you have a conversation like this. We found a mutation, it's going to cause disease. You should have chosen better parents with better genes, because there's nothing we can do for you. We don't have any treatment or thing that can happen. We don't want you to have that kind of conversation. So if you focus on actionable genes, you can tell them, we found something and we can treat you. We can make it better. Again, I want to emphasize that not everybody with mutation shows the effect of the mutation or disease, but the chance of them having disease is increased. So in the disease in my family, FLNC, the chance goes from an average risk in orange to the new risk in blue. This is the risk of showing some effect, not the risk of sudden death. That's much less, but some heart disease effect. For other genes, you can see the level of change between not having the mutation and having the mutation. In general, for dilated cardiomyopathy, if you have any of the mutations that cause dilated cardiomyopathy, your risk goes up tremendously, and likewise for hypertrophic cardiomyopathy. Okay, so down to the important things. How do you establish an order if you have a patient that has one of these conditions or that shows family history of some sort? You have two approaches. You can get total help, full service, or you can order the test yourself. And I'll show you how to do both. So full service, you would use an organization that hires genetic counselors, for example, Genome Medical or Genome Alley, and they will find the company, the genetic company, they'll suggest the appropriate test, they'll place the order, and they'll speak to the patient and you before they order the test. This will cost something less than $200 for their services. Then they'll charge you for whatever the test cost charges. And then if necessary, they'll speak with you and the patient after the test is ordered, and that will be another somewhat less than $200. Sometimes this is covered by insurance. Medicare does not cover this genetic counseling fee. Or you can skip that and order the test yourself. Most of the genetic testing companies have genetic counselors who will help you choose the correct test. And they will give you a report of the results, and we'll show you some of those reports. And they'll discuss that report with you at no cost. And they will speak directly with the patients at no cost and tell them what it meant. So what kinds of orders might you or your Genome Alley company order? If you've been told that your patient's sister has a mutation in FLNC, then you want to sequence just that one gene. So if you find there's a family history, you get information about sequencing a single gene, that's what you can go ahead and do. It's the simplest thing. And right now that costs about $250 self-pay. Insurance gets complicated, but insurance will probably cover it. It'll probably cost less. You want to use a CLIA, clinical laboratory approved laboratory. So the test is not a research test, but a clinical level test. Another simple approach is if you have somebody who has disease, hypertrophic cardiomyopathy, there are disease panels that you can pick out, and I'll show you one example of how to do that. And these panels test between 20 and 200 genes, depending on the panel. And right now they cost about $250 self-pay. So you choose the panel from the website, you talk with the genetic counselors and physicians to help you choose the best panel for your patient if you wish. And there's also some free sponsored testing. Invitae now will test for cardiomyopathy, arrhythmia for free if you contact them. Okay. So let's look at one example. This is if you go into the company GeneDx, and you can see all the many diseases that they provide sequencing for. but you're going to be probably interested in cardiology. So if you click on that, you're going to pull up a panel where they tell you you can test for any of these kinds of things in cardiology. Suppose you are interested in cardiomyopathy, then they'll pull up the actual tests. And there's, you could, if you have a patient with dilated cardiomyopathy, you could choose that panel. I generally recommend choosing the combined cardiac panel. That's going to give you something for everything here. The downside is you're going to get a lot of variants of unknown significance. If that's going to worry you, then this is not, the fewer genes you test, the fewer variants of unknown significance you get. But if you don't get a result here, then you might then go with another panel, and each time it's going to cost $250. So if you do it all at once, it's the same price and you get more information. So if a mutation is not found, suppose you do the full cardiac panel, no mutation is found. Does that mean that the heart disease is not due to a mutation? Let's see if you can put this in chat. Give me a yes or no. Are we getting responses? Okay, if we're not getting responses, then I'll just go ahead. Let me know, Jenny.
We got a few. So no.
Okay, it does, very good. It doesn't mean that the heart disease is not due to a mutation, because we don't know all the mutations yet. So since we don't know all the mutations yet, what are you going to do? You're going to test again in a year or two. Maybe research has caught up with us and we now know that mutation. But what are you going to do about the family? The recommendation is to do clinical screens for first and second degree relatives until we find out if they have the mutation. So you're going to check them or warn them to get checked. So family history can be very tricky. Even if someone has the disease-causing mutation, they may or may not show disease yet or ever. That's what we call penetrance. That's the chance that the mutation causes any effect. There's another term that we use is expressivity, and that's the level of effect caused by the mutation. It might cause an effect, but so minor that the patient isn't even going to notice it. So types of orders for the disease, you can have, we talked about a single gene mutation, you can order disease panels. Nowadays, there's something called whole exome sequencing, where every single exome, all 23,000 of them, can be sequenced. That's only 1% of the genome, because the rest is in introns and between genes. That costs nowadays something under $2,000, or if you're going to do a trio in the family to help deal with variants of unknown significance, it's still somewhat less than $3,000. And now sequencing has become cheap enough that there's even whole genome sequencing, where they're going to sequence everything, introns, between the DNA, between the genes. And that costs something like $2,500 for an individual, or for trios, $5,000. So if you do whole exome or whole genome sequencing, what happens is you give the genetic company, the genetic testing company gives their computer the entire sequence, exome or genomic sequence, and the symptoms that the patient has and the family history. And HAL spits out an answer. And I've done this and been very disappointed to get nothing relevant found. Okay. But what genes did you test? Well, we can't tell you that. Only HAL knows the genes that have been tested. So that's the downside. You don't have a list of the genes that were tested, just that HAL decided there's nothing relevant, try again in a year or two. If you do panels, the problem is that the panels get out of date and it's fairly expensive for them to add a new gene. And so they are updated much more slowly than this software is going to be updated. So now I wanted to show you my family, give one case history. I'm choosing the case history in my family. We've talked about my niece who died suddenly at age 36. And her mother had dilated cardiomyopathy. And so it was assumed that my niece inherited the mutation from her mother and that mutation was dominant. So that meant that I had a 50% chance of inheriting that same mutation from either of the parents. We didn't know which parent. Am I backwards here? This is my sister. So I would have a 50% chance of inheriting the mutation from either of the parents. We didn't know if it was my father, although he had a heart attack at age 66, or my mother, who had other issues, health issues. She died of a stroke. So since we didn't know the mutation, my physician, Elizabeth McNally, suggested that we should get yearly echocardiograms. Both I and my nephew, who had a 50% chance of getting that mutation from his mother, and my children, who had a 25% chance, 50% if I had it, but I only had a 50% chance. And so my husband wasn't too thrilled about this. He didn't want to frighten the kids. So we compromised. The idea was I could tell them about this once, but I couldn't remind them every year. And it turns out that my daughter got echocardiograms every year, but my son did not. And the reason he didn't was he went to his doctor, and his doctor told him that it wasn't necessary for him to get echocardiograms because his mother, me, was healthy. I didn't have cardiomyopathy. So was that the correct statement from the doctor? Yes or no? So we're running out of time here. Do we have any yeses or nos? Or I'll just go ahead and tell you, at least you're thinking about it, that this doctor didn't know about penetrance, didn't understand that I could still have the mutation and not have the disease. So that was very upsetting to me to discover 10 years later that my son had never gotten tested, never been followed up with cardiomyopathies. So let me quickly show you what kinds of things you can expect to get from the genetic testing companies. This came from Invitae. It tells you that this is the mutation that was in my family. You don't have to worry about what that mutation is. It's telling you it's pathogenic. It's heterozygous and it's pathogenic. And that it's associated with autosomal dominant cardiac and neuromuscular conditions. They give you a lot more. So they will describe how frequently it occurs. It's causing arrhythmogenic cardiomyopathy, dilated cardiomyopathy. It's associated with sudden death and loss of function mutations. They also give you some clues on management. If the patient doesn't have any symptoms yet, you can test to see if there is some heart damage with electrical, structural, and functional evaluations. They give you some clues on treatment. Options for cardiomyopathy may include, and they're suggesting beta blockers. That's if there's cardiomyopathy, calcium channel blockers. If it's bad enough, implantation of a cardiac defibrillator or even heart transplant, and suggest referral to experts. So the number of actionable genes, we hope and expect, will be increasing in years to come, not too long from now, because we don't only have to check action, have action by treating disease, but we could actually treat the mutation, genetic treatment. And for example, there is now a genetic therapy for spinal muscular atrophy. The treatment actually replaces the mutant gene with a new working copy of the gene. They do this by infecting the patient's cells with a virus that, instead of carrying virus genes, carries the new genes for this SMN gene that they're missing. And this one-time treatment gives them a lifetime cure. So the take-home messages today are that genetic testing can lead to early treatment and protection for your patient and their family, and you can prevent sudden death. But genetic testing is only useful if there's follow-up clinical care. And targeted testing is essential if the disease in your patient is frequently caused by mutation, even without his family history, or if you have a disease that may not be often caused by mutation, but there is a family history of disease, you still want to test it for genetic testing. And I want to stress that family history is often not obvious because of penetrance. Even though you have the mutation, you're not showing disease or misdiagnosis. And now I want to go back and end with my family history. I forgot to mention that my father's brother died at age 4. And we were told for over 100 years that that was because of a terrible accident. His mother was a dressmaker. She died in her sleep at age 60. They said it was a heart attack. No autopsy was done. She told everybody that her mirror fell on her boy, and this huge, heavy dressmaker's mirror killed him at age 4. And my father, his brother, all of us believed this for over 100 years. But I was collecting information for my book, and I decided to find out what kind of injuries this boy, Eugene, what did he suffer when the mirror fell on him? And when I got the death certificate, I was shocked to discover that he had no injuries. No dressmaker's mirror fell on him. He died of congestive heart failure. And my grandparents moved and hid and lied of the cause because they didn't want to hinder the marriage prospects of their other boys. So that's my family story, and I'm ready for questions. I did have them Jenny send you this list of some, not all, of the genetic testing companies that you could work with. 2 of them are the full service. The rest are companies that you would deal with directly. And then some online, if you're interested in genetics, some little online courses that I thought were cool. Okay, so now if I can figure out how to stop share, which I'm not sure. Could you stop share so I could see people? Or maybe let's leave it in case I want to go back to a slide. Let's deal with questions if there are, please. Okay, maybe I'll end slideshow. Yeah. Okay. Okay, so I can see you now, and
like skip the statins is okay, or
I think, yeah, I think for someone who's younger, generally if the calcium score is low, then we forego the statin. There is a possibility of it missing like soft plaque because the calcium, right?
I think Justin.
I am not hearing
That is
the
directly
question.
possible, but based on the guidelines, really the
Somebody text Dustin to turn it off.
at risk, and if they otherwise don't have any strong indication to be on the
Dr.
statin.
Liebman, this is Uma Srivatsa. I'm an electrophysiologist here at UC Davis. Hey, that was a phenomenal talk. Starting from basics, very nicely built the story, especially of your family history. So I am one of the people who frequently screen patients, given the nature of my work. But as you correctly pointed out, very frequently I get VUS.
Mm-hmm.
My question regarding that is the onus on us to future follow up 5 years from now, because we don't know how fast the field is growing. So, or if as the data accumulates and it gets projected as a pathogenic gene in the future,
Mm-hmm.
will the companies notify the patients?
No, and I've been asking them, and we can keep all complaining to them that they should be doing that. They do not. There are some companies that will actually retest So they cost much more than the companies that don't do that. Actually, the companies that don't even provide a genetic counselor, I found you have to call. The different companies are different and they change all the time, unfortunately. But there are some that cost, $1,500 to do their testing, but they will test again in a year, and a year after that, they'll provide a little follow-up, and they'll even do trio testing for that. But there's no genetic counselor. So you can call them and they'll answer your questions. Right now, most of the companies will give you an answer once, and then it's up to you or the patient to follow up. Again, I wish that they would call you. Not only don't they call you back because there's your variant of unknown significance is now classified as pathogenic, but they won't call you back to tell you we've got 5 new genes that you should test again. So I would put that in the same category, that maybe you have to put the onus on the patient that they have to get tested again. But if you put it in your record to test them again, because the field is moving very quickly, and I wouldn't do it. Some of them are selling you things where every month they're checking it. I mean, that's overkill. But once a year, getting retested nowadays makes a lot of sense to me. And the other thing I should mention is, different companies. I was very disappointed with LabCorp. So I actually have someone in my lab who has this family problem, and her doctor didn't know where to sent her to LabCorp, and they wanted to charge her $10,000 to do a small panel, not even the full panel that you get in Invitae. Then when I called them, the price was $5,000, and then they don't give you a straight answer. And Quest, another company you guys probably love because we all know that company. They had it offered. Now they took it away. I think they're going to offer a cardiac panel again. Their panel was missing lots of genes. It didn't have FLNC on it. So one thing you might do is check the panel and make sure it has at least the 81 genes that are currently recommended by American Council of Medical Geneticists. And then next year there'll be more than 81 genes. If a testing company doesn't have that, it's not keeping up to date at all. Right now, GeneDx and Invitae are the standard. They've got everything and it's cheapest, but that may not be true next year. So yeah, I hope it keeps getting better, and it's not going to. Each company has their own panel. But some kind of testing is better than no testing. And full genomic or full exomic testing will get cheaper and cheaper, and that should be updated all the time because they have all the genes. And so as that gets cheaper, that's something to consider. Right now, there's direct-to-consumer testing. And I think it's Newport. I'm blanking on the name of it. They have a sale for $543. They'll sequence the whole genome and give you a report, they say, for lifetime. Whether that's really true or not, I don't know what lifetime means. But that's direct to consumer. It's not through physicians. So those are the things that I know of. It is a fast-moving field. In general, the prices will be going down, but there are some scalpers out there that you have to watch out for.
Is there any other questions? Okay, if not, then it's 9 o'clock. Thank you so much for a wonderful talk, Dr. Liebman.
Okay, and I did send these. Thank you so much for the invitation and for the questions. And I hope you'll consider genetic testing for your patients and not be frightened away by some of the concerns. It's really just like, shopping for the best air conditioner. It's not any worse than that. And I did send you, oh, one last thing is banking your patient's DNA, or just banking your DNA. We didn't know if it was on my father's side or my mother's side because we knew the mutation, but we didn't know who had the mutation. Now you can bank your DNA, and Securigene, one of the companies that I list as the resources, will do that and give you a tube that's stable at room temperature of your DNA that you can test later. Okay. Thank you for the invitation. Bye.
Thank you. Have a wonderful day. Bye.
Thank you so much.
Oh,
Thank you
it's
so much.
Lieu. My daughter-in-law is Liu. Okay.
Yeah, some people spell it. It's the same character in Chinese.
Okay. Okay. So maybe we're related.
Bye.
I'd love to give this kind of talk elsewhere. If you know of any other, either for cardiology, or I have a talk just for general medicine.
Oh, okay.
I haven't had too much luck when I tried to sell this, except at UNR. I haven't tried that hard because then I got involved in writing the book. But I would love to give such talks, because when I talk in the medical school, it's amazing that the students still think it costs so much money and don't want to think about recommending it to their patients.
Okay.
And so we
We'll
want to
definitely pass on the information. Yeah.
It's hard because their teachers think that. And so it's very hard to change the culture.
Yeah, definitely.
So, all right.
All right.
Again, thank you. Great to see you, Ping. Thank you for the invitation.
Bye.
Thank you so much again.
Bye-bye.
Yeah, bye.
Thank you, Dr. Liebman.
All righty. Thank you, Jenny, for
You're
setting
welcome.
everything up and arranging everything so nicely. Thank you very much.
Oh, no problem. Thank you. Have a good weekend.
And oh, if you're going to have, if you have a recording, if you could please send it to me, I'd
Oh,
appreciate
yes.
it.
I'll
Thanks.
send you a copy.
Okay. Bye-bye.
And I'll forward this to everyone because I know you send this information to me.
Yes.
The resources.
Resources, please. Yeah. Okay.
Thank you.
Sure. Bye-bye. I don't seem to be able to leave the meeting. I keep trying, but I'll just